Okay, so remember, bariatric surgery is a last option, okay? These individuals that are going to have bariatric surgery must be screened very closely. Most insurance companies will not pay for the procedure unless the patient has been under the care of a physician for 6 months showing weight loss, mainly showing that they can follow a very strict regimen, because this is what's required after bariatric surgery. They have to go through a psychological, physical, and behavioral screening, and they have to go through extensive pre-op teaching before they can have surgery. It is generally held for someone who has a BMI greater than 40 or someone who has a BMI of 35 and has severe medical issues. And so once again, they must be screened. We're looking at your book. You have page 917 and page 918 that have a chart and some pictures of the different types of surgery. Gastric plication, though, is not in your book, but it is increasing in popularity. And this essentially maintains the stomach and doesn't cut anything away, therefore it's reversible. But what they do is laparoscopically, they actually sew over or one or more large folds into your stomach. And by doing this, they decrease the stomach volume by up to as much as 70%. And so the stomach is able to hold less, they eat less because they feel fuller, all right? And the stomach maintains its normal function when this is done. So it is reversible, though, and if needed can be turned into a different procedure. We look at the vertical sleeve gastrectomy, and this, though, does involve cutting away approximately 85% of the stomach, and obviously reduces dramatically the size of the stomach. It does preserve the function of the stomach, but by cutting away part of the stomach, it will eliminate some of the hormones in the stomach that are associated with, for instance, hunger, hormones that stimulate hunger. Okay, continuing on, the Roux-en-Y gastric bypass is probably still the most common type of bariatric surgery, all right? And what happens is the surgeon actually goes in and you can see creates a very small pouch. So cuts away the majority of the stomach and takes a very small pouch and creates that, and that is your new stomach. It gets filled up very quickly. Then takes a portion of the small bowel, connects it to the pouch, and then the distal end of that is then attached to or sewn to the last part of the small bowel, or the ileum. And so what happens is you feel full very easily, and then the majority of where the digestion, where the calories and the nutrients are absorbed, is bypassed. The portion of the stomach and the small bowel that are actually cut away are then reconnected to some part of the colon. So digestive juices and hormones are still produced, and they have a way to actually escape the body. I did put on here, though, that the Roux-en-Y, these individuals, while very successful, they lose, a huge amount of weight. They can suffer from dumping syndrome, and we will talk about that. Another thing that can be done is called the adjustable gastric banding. This is a simple procedure laparoscopically where a band is actually placed at the upper portion of the stomach. It's tightened, and so it gives the sense that you're full because you have a very small portion of the stomach, and then the food essentially then still passes through the normal means of digestion. You can see that there's a port, and know that this port actually allows control of that band, and so it can be increased or decreased to actually affect the size of the stomach. The problem with the adjustable banding is it can be stretched out, okay? So that is something that has to be watched. It can, though, be modified or reversed, and if needed, they still have the option for another type of surgery. Sometimes it's a start, it's least invasive, so those individuals that are, great risk when you put them to sleep because of their morbid obesity, this might be a start. They get off some of the weight, and then they could go into a more permanent type of gastric bypass. Okay, nursing diagnosis for obesity would be imbalanced nutrition, more than body requirements. We've kind of gone over what we need to do for someone who has and suffers from obesity, and going with the simple plan that we would assess their past medical and surgical history, help them to establish goals, help them to establish what would be the desired outcome, encourage them to get in then to that calorie deficit, to lose their weight slowly, to do so by diet modification and exercise, and then possibly adding medication. And remembering that bariatric surgery is a last thing that we would do. Activity intolerance, this would be something that would need to be monitored for carefully, and patients would need to be taught to increase their activity gradually. Chronic low self-esteem has to do with the fact that these people have suffered from obesity, morbid obesity, often for a lifetime. Even if they have lost weight, there's an excellent picture on page 918 that shows you what happens when someone has lost a significant amount of weight, and then their tissues are stretched. And so often after someone has lost all their weight, skin reduction surgery would seem to be the next logical step, and this is an excellent picture of skin reduction surgery, but keeping in mind that the majority of healthcare plans do not cover skin reduction surgery. We're actually going to focus on ineffective therapeutic regimen management, and we're going to focus on that from the standpoint of someone who's had bariatric surgery. Okay, so someone who's had bariatric surgery, first pre-op, you know what, we want to make sure we're well prepared. Do we have the appropriate blood pressure cuff? Is the bed one that can handle someone who suffers from morbid obesity? How are they going to be transported? Do you have a bariatric size wheelchair on your floor? So we want to make sure we're well prepared. We need to look at their past medical history. We need to make sure that if they suffer from sleep apnea, that we need to know if they use CPAP, which is continuous positive airway pressure. If so, we need to know, are they going to bring their own machine from home, or are we going to provide them one? So sleep apnea is huge in individuals that suffer from morbid obesity. It needs to be identified. Everybody needs to be aware of it. Once they have surgery, one, you're taking care of a regular post-op surgical patient that you guys are used to taking care of, okay? Just a couple of things. One, we need to make sure that they don't develop any pulmonary complications. We've got to get on it, turn, cough, deep breathe, early ambulation. Often that evening, they're up and about. We want to make sure that they do not develop a VTE, so we are teaching them calf pumps, ankle rotations, monitoring for VTEs. We want to make sure that we keep the head of the bed elevated at least 35 to 40 degrees. This helps to reduce abdominal pressure and improve pulmonary function. Remember that a majority of the anesthetic agents are actually stored in adipose tissue, and so there could be potential resedation, so we would monitor for that. Also, these individuals have got to have end-tidal CO2 monitoring. Okay, so when they come back, most care bundles say if their BMI is between a certain number, they have to have CO2 monitoring at the bedside. Special considerations for you as the nurse when they're still in the hospital. One, obviously we need to manage their pain. Two, we need to know that postoperatively they often only receive small amounts of water and sugar-free drinks. And so these are usually given 30 mLs every 2 hours while awake, and we are teaching them, reminding them, they've already been taught this, but reminding them that they need to eat slowly, or sip slowly, or stop eating when they feel full, okay? And once they tolerate the liquids, they will be advanced to solids. And then they must be reminded that they should not take fluids with meals, okay? When they're going home, we need to make sure that the patient understands everything that they were taught in their pre-op classes. Their diets typically are high in protein, low in carbs, fat, and roughage. They're taught to eat 6 small meals daily, and that fluid should not be ingested with the meal, and that fluid should be restricted to about 1,000 a day, okay? We remind them that fluids and food high in carbohydrates tend to promote diarrhea and signs of dumping syndrome. These guys can suffer with lifelong issues, including anemia, vitamin deficiencies, diarrhea, and possible psychological problems. Weight loss is usually rapid the first 6 to 12 months and then tends to stabilize after that. Remembering that this massive weight loss, though, often leaves the patient with large quantities of flabby skin, and hopefully they can have reconstructive surgery. So just make sure that you're very clear on the postoperative care of someone who's having bariatric surgery.